Good evening, everyone. I think I will call us to order now. My name's Glenn Lowry. I'm the Merton Stoltz Professor of the Social Sciences here at Brown and a Faculty Fellow at the Watson Institute. And it's my pleasure to welcome you on behalf of the Africa Initiative at the Watson Institute to this panel on the political, cultural, and epidemiological implications of the Ebola outbreak. We have been watching recent events as they unfold in West Africa with alarm and an abiding concern. It seems to us that this outbreak is a looming public health catastrophe which could have enormous consequences in the region with humanitarian, political, and even cultural implications. Indeed, the heated debate over public health policy that has emerged here in the United States in reaction to the advent of a relatively few cases makes clear that these implications extend well beyond West Africa proper. So this panel, which is co-sponsored by the Brown University's Global Health Initiative and by the Department of Epidemiology and the School of Public Health here at Brown, will attempt to weave together a variety of perspectives from the worlds of infectious disease medicine, the social sciences, and public affairs. Allow me to introduce now the moderator for tonight's panel, Dr. Patricia Agupusi, who will introduce the other participants and describe the planned program in further detail. Dr. Agupusi is a postdoctoral fellow at the Watson Institute, specializing in the political economy of development in Africa. A native of Nigeria with a background of study in philosophy, international economics, and law, she earned her PhD in international development studies from the University of East Anglia in 2010. She's the author of a number of research articles appearing in peer-reviewed journals, and her book, Homegrown Development in Africa, Reality or Illusion, co-authored with Chuks Okereke, will be published next spring by Routledge in their Studies in African Politics and International Relations series. Dr. Agupusi.
Thank you for that impressive and generous introduction. And thank you all for coming for this event, and I think it's a critical event, and we hope we'll get something substantial today. And on the panel today, we have 4 people on the panel, and we're yet to see one of our panelists. We hope that she will be here very soon. The first person that will speak today will be Dr. Adam Levine. Adam is the Assistant Professor of Emergency Medicine and Director of the Brown University Global Emergency Medicine Fellowship. This year, he traveled to Bond County in central Liberia to help International Medical Corps to set up its very first Ebola treatment center. Adam will use his experience from Liberia during this tragic time to give us a talk on the impact of Ebola virus disease and strategies for outbreak response. And this will follow by Nisan Shorev. Nisan is the Hammond Family Professor of Sociology and International Studies at Brown University. Her research interest is in the area of international political economy. She also works on trade, health, globalization, international organization, and social theory. She is the author of the World Health Organization Between North and South. And today she'll be speaking on the role of WHO in this outbreak of Ebola. And from there, we'll be hearing from Professor James Moroney, who is the John Herzing White Professor of Political Science and Public Policy and the Director of the Tobin Center for Public Policy at Brown University here. Among many of his work, Professor Moroney is noted for his work on health politics and policy and on popular participation and morality in American politics and political development. Today, he will be speaking on the politics of Ebola in the US. And we'll be hearing also from Dr. Nicole Alexander Scott, who is Assistant Professor of Pediatrics and Medicine at the Warren Alpert Medical School of Brown University. She has been serving with the Rhode Island Response Unit, and she'll be is speaking with us today regarding the response units of Rhode Island on Ebola. We hope that she'll be here. She's not yet here, but we're hoping that she's on her way because she confirmed that she's excited to be here. And after the talk, I think for the procedure today, it's going to be 10 minutes. Our speakers will speak our panelists will speak for about 10 minutes. And this is to give us enough time for question and answer. We know that there's a lot of burning questions that people would like to ask. So we hope that we all stick to that 10 minutes. And after they have spoken, I'll give a brief talk also on political culture and culture of the implication of culture in the containment of Ebola outbreak, and also how Nigeria was able to contain Ebola. Thank you. And now we'll be hearing from Dr. Adam Levin. Thank you.
Right. Thank you, everybody, and thank you for having me here. So I am generally an emergency physician. I work at Rhode Island Hospital and at the Miriam Hospital. I train residents and medical students in emergency medicine. And I'm also a member of the emergency response team for a humanitarian organization called International Medical Corps. I've deployed with them a few times in the past, and I was asked to deploy with them in August to Liberia as part of their epidemic response. So I'm going to just talk a little bit about my experiences there in Liberia and what I learned about the epidemic during that time. So I first want to start with a story, and the story begins here at Phoebe Hospital, which is a small rural hospital in Bong County, about 120 kilometers north of Monrovia in Liberia. On the night of June 23rd, a woman walked into the emergency room of this hospital. She had a headache and fever, some nausea and some vomiting. Though there had been an epidemic of Ebola raging in Guinea, just a couple hundred miles to the north, for over 4 months at this point, the doctors and nurses who worked at Phoebe Hospital didn't recognize these symptoms. They'd never seen Ebola before. To them, headache, fever, nausea, vomiting meant malaria or typhoid. Reasonably enough, they admitted the patient to the internal medicine service of the hospital. They started her on some anti-malarial medicine, and they planned to do some blood tests in the morning. By the end of the week, 7 of the nurses who were caring for the patient would fall ill, and within a week after that, 6 of them would die. Around this time, all of the other staff at the hospital, seeing their nursing colleagues falling ill and dying, abandoned the hospital. And within short order, all of the patients who could walk did just that as well. But by that time, many of them had already contracted the disease from the nurses who had been taking care of that first patient, and they brought it back to their villages and towns all across Bong County. Over the ensuing weeks, the epidemic spread through the county. Nearby Cuttington University, which is one of just 2 nursing schools in all of Liberia, shut down as many of their nursing faculty and students became ill. All of the other hospitals in the entire county shut down. All of the public health clinics in the county and most of the private clinics also shut down as nurses and doctors became scared to go to work. The Ministry of Health redirected all of its activities to fighting the epidemic. As a result, all vaccinations in the county stopped. All malnutrition screening stopped. All antenatal visits for pregnant women stopped. Essentially, this pattern was repeated across Liberia to the point where, by the time I arrived in late August, there were almost no operating health facilities in the whole country, just a few private clinics that were still operational. And I think that's the main lesson that I learned while I was there about Ebola virus disease, is that it's not just a disease of individuals, it's a disease of healthcare systems. And the weaker the healthcare system, the more vulnerable it is to this virus. Unfortunately for us, Africa is full of weak healthcare systems, and that's what makes this particularly scary. So the context in Liberia, similar to Sierra Leone next door, is that it's a post-conflict environment. It just emerged from civil war less than 10 years ago. Also has very porous borders between Sierra Leone, Guinea, and Liberia, which allowed the virus to spread quickly through those three countries. Increased mobility of people in the region. As these countries are developing and laying down more roads, it's easier for people to get supplies, it's easier for people to get medicines, and it's also easier for people to move around and bring the infection to other places. The healthcare system was already very weak. In fact, in Liberia, there were only 50 doctors for all 4 million people before the epidemic began. And you also had really poor infrastructure in terms of sanitation and hygiene, and general mistrust of the government, which made efforts to stop the spread of the virus even more difficult. So this is the state of the epidemic currently. This is actually a week old. There are new figures that just came out today. But as of a week ago, there were over 13,000 cases, about 5,000 deaths, including 523 healthcare workers and about 269 of them who died. But what's missing from these numbers is really the untold numbers of secondary deaths from other diseases. There's an estimate, for instance, that maternal mortality is likely to skyrocket and has been skyrocketing in Liberia. Before this epidemic began, about 1 out of every 150 pregnant women would die during their pregnancy. And the estimate now is that up to 1 out of every 7 could die during pregnancy, just because of a lack of access to pregnancy-related care. The Centers for Disease Control in the United States estimates that the epidemic could reach over 500,000 cases by January, or alternatively, it could be over by January. And all of that really depends on whether we can break the chain of transmission by isolating up to 70% of all new cases in Ebola treatment units or other types of facilities that can prevent patients from spreading it to their communities. And so really, whether or not this epidemic grows out of control or is over in a few months completely depends on the humanitarian response and what we do. So I'm just going to go quickly through some of this. Ebola virus, we think its natural reservoir is fruit bats, and it's transmitted from fruit bats to humans. But really, that's only important for the very first case. And after the very first human is infected, the outbreak is amplified purely by human-to-human transmission. And that transmission occurs through body fluids. Pretty much any body fluid can transmit the virus. The most common are blood, vomit, diarrhea, but urine, semen, saliva, sweat, breast milk can be passed from mother to child. In childbirth, it can be passed through breastfeeding. It can be passed sexually. So any of these body fluids can transmit the virus. And really, the people who are most at risk are the small number of people in this world who spend a lot of time with the body fluids of sick people. There aren't a lot of people whose profession involves dealing with the body fluids of sick people, but the main profession that does is healthcare workers. And so this is a disease that targets the caregivers. So in rural communities where it's often the mother or the wife who's providing care for a sick loved one at home, they're the ones who are most at risk for infection. And then in the hospitals and clinics, doctors, nurses, nurse aides, cleaners, registrars, lab technicians, pharmacists, traditional healers, all of them are at risk for contracting the virus. Also, transport personnel like paramedics, EMTs, and especially in Liberia and Sierra Leone, where a lot of pre-hospital care is actually provided by taxi drivers, who are the ones who bring people to hospital. They're at very high risk. And then everyone who deals with the dead, because actually the viral load increases as you get sicker, which means that the sicker you are, the more infectious you are, until you die, and then actually at death, you're the most infectious. So dead bodies are by far the most infectious, and anybody who's dealing with the burying or washing or cleaning of dead bodies is at high risk for contracting the disease. So that's how it spreads. And this is how we respond. And actually, this response structure is not new. It's been worked out over decades. This is not the first Ebola virus epidemic that we've seen. There's been over 24 in the past 20 years. And MSF, Doctors Without Borders, which is the main organization that's responded to these outbreaks in the past, has developed a very specific system for responding and ending these outbreaks. And it's worked the last 24 times. We believe it can work again if it's applied on the right scale. So this starts with a number of components: health promotion, which means educating communities about what to look for; Ebola screening, which means setting up systems to identify patients who may have Ebola virus disease, who may be at risk for it; Ebola testing, having the laboratory facilities to determine who does and who doesn't have Ebola; and then finally clinical care, which really involves isolating patients and treating them appropriately to reduce their mortality, but also to reduce the mortality of everybody else around them. So health promotion involves a lot of education. And actually, when I was in Liberia, this is one thing that I thought the government of Liberia was doing very well. Pretty much everywhere you went, there were signs about Ebola being real, about the different signs and symptoms of Ebola, the ways people could protect themselves. Radio is a very big and popular media source in Liberia, and on the radio you couldn't listen to it for more than 10 minutes before hearing a message about Ebola. There were rap songs about Ebola, there were hip-hop songs about Ebola, there were children's songs about Ebola. It was pretty much everywhere that you went. And I thought that for the most part the population was not ignorant of Ebola. In fact, they were hyper-aware, hyper-knowledgeable about it, and very surprisingly to me, far more knowledgeable than Americans were when I returned home. And that's partly because of the excellent and really consistent media messaging that was going on in Liberia, and very different from the irrational and inconsistent messaging here in the United States. The second aspect is surveillance or contact tracing, and this is how cases are identified. And Liberia also had a pretty strong system which worked actually best in the rural counties. They had community health workers in each village who would look for patients who were exhibiting signs of Ebola, and if they found them, they would report them to the county surveillance team, who would then go investigate. And when they found a case that met the definition for a suspect case of EVD, they would call us at the Ebola treatment unit. We would come bring that patient to our Ebola treatment unit to test them and to treat them. So this is the system in place to identify new cases and prevent those cases from spreading the disease to others in their community. And then finally, the last aspect is case management, or the Ebola treatment unit. And this is really where I had the most experience. I helped International Medical Corps set up its first Ebola treatment unit ever, and that was in Bong County, Liberia. And we opened our Ebola treatment unit here on the 15th of September. And our Ebola treatment unit was actually located on the site of an old leper colony, which I thought was a really sort of great irony. In fact, a lot of our guards were formerly patients with leprosy who'd been treated years before, or the descendants of patients with leprosy who'd been treated years before. And they were pretty much one of the only areas in the county that was open to us setting up our Ebola treatment unit there. There's a lot of stigma, and as you can imagine, most people didn't want an Ebola treatment unit in their community. So the lepers welcomed us with open arms, and we set up the unit. The Ebola treatment unit is a very specific type of structure. It's like no other healthcare facility, and it's designed in a very specific way. It's split into a low-risk zone and a high-risk zone, and all patients are in the high-risk zone. And that's split into a suspect area and a confirmed area. So people initially come through triage into the suspect area while they're awaiting testing. If they're confirmed as having Ebola, they move to the confirmed ward. If they don't have Ebola, they are immediately discharged. This is a one-disease hospital. If you don't have Ebola, you get out as quickly as possible so you don't catch it from your neighbors. The setup is made so that you reduce the risk of transmitting Ebola within the unit or from the unit to the outside. So all the waste is actually burned, and that requires an incinerator. You have a specific morgue set up to handle dead bodies, and you have laundry areas where everything is chlorinated that's going to be reused, and so that it is disinfected. So it's a very complicated setup. It's also very expensive to run. It costs about $1 million a month to run an Ebola treatment unit. So the Ebola treatment unit is different from any other health facility I've ever worked in. And I've worked in a lot of resource-limited settings. I've set up clinics in refugee camps, and I've also set up field hospitals in war-torn areas. And this is completely different in the sense that every other health facility I've ever worked in, the first and primary goal is to care for patients. And in this, the first and primary goal is to protect your staff. And caring for patients comes second. And so that was a huge amount of what we spent our time on. This is actually some of the staff that we used to open the Ebola treatment unit on our first day. We had about 50 or 60 staff members to start, and now it's almost 200 staff members. About 90% of those were local Liberians, so individuals from the area. Some of them nurses, some of them physician assistants, some of them cleaners, some of them burial team members, some of them chlorinators, all sorts of different jobs that people had to keep it running. And protecting our staff meant maintaining an adequate supply chain of the personal protective equipment, and that actually is not easy because it's hard to get materials and supplies into rural Liberia, and the equipment is very expensive, and it's hard to source on the international market, especially now that it's in such high demand. It means maintaining an adequate supply of chlorine for disinfection. The ETU went through about 12,000 liters of chlorine a day, so it's a lot of chlorine. It also means enforcing really strict protocols, making sure that everyone is dressing appropriately in the protective equipment, and that when they're undressing, they're doing it in the right sequence so that they don't contaminate themselves as they undress, and they're being sprayed down with chlorine. So no one's allowed to dress or undress on their own. They have to be observed by a safety monitor while they're doing it. And then all of these protocols and all of the protective equipment is meaningless if people aren't well trained into how to use it. So a lot of what we did the first week was really training our staff and training everyone to feel comfortable working in the PPE and to be able to manage all the protocols in the Ebola treatment unit. The second goal is patient care. And it's also still very important, though, because not just in terms of making sure your patients survive, which is what we all want to do, but it's also important because if people think that everyone who goes into an Ebola treatment unit dies, then no one is going to want to go to an Ebola treatment unit. Why would you go to a place where you're only going to die? So having people do better when they come out of the Ebola treatment unit than when they went in is really important, just from a public health perspective of getting more people into the Ebola treatment unit. So this was actually one of my patients who was a nurse at Phoebe Hospital who became ill. She was very sick for a while in the Ebola treatment unit, but survived. And a colleague actually just sent me this picture because she is now working in our Ebola treatment unit. She's recovered from Ebola, which means that she's immune as far as we understand, and that's very helpful because she's able to work with the patients without fear of getting sick herself. The ETU depends a lot on lab testing. We cannot turn patients over. We can't move someone from suspect to confirmed if we can't get a lab test to show that they have Ebola. And the whole functioning of the unit really depends on this lab testing for Ebola, which is very complicated. It involves a polymerase chain reaction, which is a very complicated sort of test. It has to be done in this sort of hooded BSL-4 type setup. And so having these types of mobile labs to be able to process the samples are very important. And then the clinical care itself is supportive but aggressive. Everybody gets prophylactic antibiotics and antimalarials. Oral and IV fluid replacement for diarrhea and vomiting is incredibly important. Patients can lose up to 10 liters of fluid a day, and this is by far the most common cause of death from Ebola is actually dehydration from all of the vomiting and diarrhea. We work to correct electrolytes. We do symptomatic management of patients' pain and nausea. We provide nutritional support. And then also psychological support is very important, not just for patients, for whom it is important, but also for their families who are cut off from patients because they can't visit them inside the unit. And so we have to act as a bridge to be able to let them know how their family members are doing. And then also psychological support for staff members is really important. Many of the people working in our Ebola treatment unit were stigmatized or ostracized. Some were kicked out of their communities for working in our Ebola treatment unit, and so they needed a lot of psychological support to be able to deal with that and manage it. I was also a little bit surprised to come home to the United States and find that the level of stigma and ostracization was no different in the US than it had been back in Liberia. And finally, the last step is safe burial. Again, I've opened a lot of clinics and hospitals in the developing world. This is the first time I opened up a health facility in which I had to also build a cemetery at the same time. And we cleared the space near the Ebola treatment unit for our cemetery before we even opened it. And about half of our patients do die. So a lot of patients every day are taken to be buried. So just the final thought, this is the truck that brought the gravel to our Ebola treatment unit when we were setting it up and laying the gravel down. And it had the sign on it which said, "No condition is permanent." And I thought that was a really beautiful statement about this epidemic, that this epidemic doesn't have to be permanent. We can end it, and Ebola can be something for the history books once again if we just put enough resources and support into this effort. Thank you.
Thank you for this panel, and thank you for inviting me. Adam was talking about the weak healthcare systems in Liberia, and to a certain extent it really connects to what I want to talk about. I'm going to talk about the World Health Organization and international organizations more generally, but as you will see, it's very much related to the question of what to do when at the national level the healthcare systems are weak. So when it comes to the management of diseases, international coordination has long been considered necessary. The first International Sanitary Conference took place in Paris in 1851, and it was attended by 12 countries. Many similar conferences followed. The Pan American Health Organization's PAHO, for example, was established in Mexico in 1902. In the 1940s, PAHO became a regional office of the World Health Organization, the WHO, one of the largest agencies and maybe one of the more consequential agencies of the United Nations. The WHO's constitution assigned the organization an ambitious goal. I quote, "the attainment by all peoples of the highest possible level of health." That is not an easy goal to meet. Nevertheless, over the years, the WHO took pride in various achievements, most famously the successful eradication of smallpox. Among other tasks, the WHO is also the main organization responsible for detecting outbreaks when they occur and for helping countries to contain the spread of those outbreaks. The WHO has been at the forefront of the response to avian flu and SARS in the early 2000s, and it is today at the forefront of the global response to Ebola. In the case of Ebola, however, it seems that the WHO has not met its responsibilities. Already in early April, a WHO official stated that, I quote, "This is one of the most challenging Ebola outbreaks that we have ever faced." But it was only in August, and after almost 1,000 people had died, that the WHO Director General formally declared Ebola a public health emergency of international concern. The declaration of a public health emergency has both legal and symbolic implications, in part by forcing governments and international organizations to take the situation seriously. The WHO itself has certainly been more responsive since August. The WHO provided guidance and technical support for overall coordination, surveillance, and data collection. And I was happy to see that Adam's Manual of Clinical Management was actually published by the World Health Organization. The WHO was also involved to some extent in the training of health workers, the provision of hospital beds, and the refurbishing of clinics. Other international organizations were also involved. For the first time in history, a UN mission for a public health emergency was established. Still, the international effort has so far failed to contain the Ebola crisis. Today, as Adam also said, more than 13,000 people have been infected and almost 5,000 have died. And the measures currently in place are not likely to stop the outbreak. Only 52% of Ebola patients are reported to be hospitalized and isolated. Only 22% of the 4,700 beds that are needed for Ebola patients are currently in operation, and it is difficult to find a sufficient number of foreign medical teams to operate Ebola treatment centers. The WHO estimates that it needs $260 million to meet its objectives, but so far it has received less than 50% of that amount. Why wasn't the WHO more responsive earlier on? Why is the WHO's response so essential for the containment of Ebola in the first place? And why wasn't the WHO able to respond more effectively even after it came to see the urgency of the matter? It is not lack of good intentions or sheer incompetence that stopped the WHO from providing an adequate response. But it is also not simply a blip in an otherwise well-functioning organization. Instead, the WHO's response to Ebola is a reflection of policy and organizational changes that took place at the international level in the last 20-25 years. In particular, I want to argue that these policy and organizational changes had two major consequences that undermined the ability of the WHO and the international community more generally to respond to outbreaks like Ebola. First, they undermined the WHO's operational capabilities, and second, and this goes back to Adam's point, they neglected poor countries' healthcare infrastructure. The consequences of those changes today, lack of international alertness and a dire situation of health clinics in many countries, is why Ebola is turned into an international emergency. I will identify 4 changes and the effect they had. I do not have time to explain why these changes were made. I will just say that these were strategic responses by the WHO to pressures made by rich countries and the World Bank that forced the WHO to think about health in economic terms and forced it to manage the organization and its policies accordingly. So what are the 4 changes that affected the WHO's ability to respond to Ebola? First, budget cuts. It's all about money. The WHO has been under pressure to cut its budget since at least the early 1990s and also before that. The pressure was even heavier following the global financial crisis, after which the WHO cut its budget by 20%. Today, its budget is about $2.5 billion a year. The budget cuts included 8% cut in the funds diverted to infectious diseases and 51% cut in the funds diverted to outbreak and crisis response, down to $230 million. The WHO staff charged with emergency response was reduced from 94 people to 34 people. Now, at the same time, it is important to mention that there is a separate budget line that is devoted to helping countries to respond to outbreaks on their own, and that budget increased by 32% to almost $290 million. The second issue is control of a budget. In addition to budget cuts, the WHO was forced over the years to increasingly rely on voluntary rather than mandatory contributions. Today, voluntary contributions make up almost 80% of total WHO funds. These voluntary funds are usually earmarked for specific causes, so that the WHO has little say on how the money is spent. Donors' preferences are not always in line with where the greatest needs are, and voluntary contributions are not likely to be devoted to mostly invisible tasks, such as outbreak and crisis response. Third, priorities in funding. Over the last decades, there was also a shift in priorities away from communicable diseases to non-communicable diseases, such as diabetes or cancer. Where the WHO and other international organizations do continue to concentrate on communicable diseases, they focus on AIDS, tuberculosis, and malaria, the 3 major killers. While there have been impressive gains in fighting these diseases, the programs often concentrate on immediate deliverables, particularly medicines, rather than healthcare infrastructure, including clinics and the training of health workers. In addition to lack of early alertness, the inadequacy of basic health infrastructure in the countries experiencing Ebola is proving to be of tragic consequences. Now, there's always been tension between focus on particular diseases and investment in infrastructure. Ebola is yet another proof that lack of such investment comes with a cost. In this context, it is interesting to review the WHO's justification of the budget cuts to emergency response. Because it is difficult to predict the spending needs for outbreak response work, the WHO reasoned, it makes sense that when and if crises occur, the WHO would deal with the crisis by seeking emergency funding from member states. But this reasoning, of course, ignores the time it would require to collect and utilize such funds. Maybe more importantly, it ignores the fact that some needs, such as functional health clinics and skilled local staff, require long-term investment and cannot be solved with emergency funding. Finally, organizational fragmentation of international health activities has also indirectly contributed to the failed response. The WHO, which used to be the only authority over international health issues, is now one actor among many. There are today more than 40 bilateral donors, 25 UN agencies, 20 global and regional funds, and 90 global initiatives that target health activities. Altogether, they have more than $31 billion in funding compared to the $2.5 billion that is the funding the WHO operates with. The funds come from governments or from private foundations, mostly the Bill and Melinda Gates Foundation. Such fragmentation, where different organizations have responsibility over diverse specific goals, offers many advantages. The Gavi Alliance, for example, has been fundamental in improving access to vaccines and would no doubt be a key player if a vaccine to Ebola is developed. But such organizational cacophony is ill-equipped to support the kind of local health systems that are so tragically missing in the current Ebola crisis. It seems to also be ill-equipped to respond adequately in times of crisis. Ironically, one of the many challenges in the response today, as it was in the early days of the fight against HIV/AIDS, is that of coordination among many well-meaning actors. Some would argue that the incredible work done by Medicine Sans Frontiers, MSF, in its response to Ebola suggests, on the contrary, that a fragmented, from the bottom-up response is the most effective one. Heroic volunteers and private donations have been extraordinary resources in the last couple of months. But what we really need, I believe, is a well-functioning international organization that has the funds and authority exactly to reduce our dependency on volunteers and donations. As I mentioned, there are political reasons behind WHO's current weaknesses, which would make it difficult to change. Nevertheless, we need to learn from the Ebola crisis. The budget of the WHO needs to be adequate to the task at hand. The organization needs to have some authority in regard to how to spend that budget. Priorities should not focus only on popular problems and cost-effective solutions. And while no budget could prepare us for the next global health catastrophe, there needs to be minimum attention given to basic infrastructure at the local level. Investment in infrastructure by the WHO is particularly important, given the fact that other international health entities are even less equipped to prioritize such mundane but absolutely crucial issue. International organizations are heavy, they are slow, they are bureaucratic, they are political, but they are necessary for adequate international cooperation, especially where domestic conditions make local response challenging. This is true today as it was back in 1851. Rather than writing off the WHO as a failing organization, we need to fix it so it can do its job. Thank you.
Thank you for inviting me. It's a pleasure to be here. And let me just salute Adam and all the people who've worked with Ebola patients. I'm going to talk about something very different from the data you saw. I'm going to talk about a country with 9 cases and 1 death and a panic. So my talk is the Ebola crisis hits the United States in 4 steps. And I'll give you the 4 steps. I'll tell you what's new and what's old. Step number 1, and I think in the process you see something really important about American culture and American politics, about what's happening in the United States, and about American fears. Fear number 1, an old fear, and not a crazy one, it's the fear of contagion. Oh my gosh, other people are ill, and I might get ill. And this came on very, very quickly in the United States. If you track the opinion polls, you'll find a really quite low level of fear. A poll at the very start of October asked people, are you worried that you'll be exposed to Ebola? 22% said yes, 70% no. 2 weeks later, by October 16th, it was 48-51. So about half the American population in this great fear. And with extreme cases, will you keep your children home from school? Will you not take a flight? Will you cancel trips? And roughly 1/5 of the population saying yes. Now this, the simple fear of contagion, is an old fear in the United States. I remember, if you studied the AIDS epidemic, the AIDS crisis in the mid-1980s, before people understood how AIDS was transmitted, and back in the era when the diagnosis meant death, as we used to say back then, there was the same kind of panic, even more. The mayor of Atlanta at the time thought it would be a good idea for people who were working for the city of Atlanta to confront and understand AIDS. And so he set up a panel of people from AIDS Atlanta, which was an organization of people trying to get AIDS mainstreamed and taken seriously. And they filled an auditorium with officials from city government in downtown Atlanta. And the first speaker from AIDS Atlanta got up and began with what at the time was a dramatic announcement. He said, I am a person with AIDS. The consequence, people began to scream. The people in the front got up and began to run, and everybody ran out of the auditorium. They just panicked and left. That was the end of the session. I talked to one of the people who had been one of the panickers, and she said, well, I have children. I don't know how you get that disease. I didn't know of being in the same room. I was going to get out of there. If they fired me, so be it. So, panic over disease, an old story. Step number 2, politics. The politicians jumped in. You can actually pinpoint the week of October 21st to October 25th, right after the public opinion polls picked up the panic in the general population. There were, by one count, in that 1 week, 734 advertisements about Ebola, about unsecure American borders, and about Barack Obama. As one candidate for the House, now a representative, said, we need a no-fly zone from that region of the world. We need to send a signal now. Our borders are closed. There are no direct flights to West Africa and the United States. What you'd have to do is shut down the flights to Paris. But the appeal was very powerful. The New York Times, playing off the feelings of anxiety about Ebola, is a powerful strategy motivating the Republican base. So the Washington Post, people who study American politics are always looking for the October surprise. What's going to happen in October to change the election? As the Washington Post put it, we have our October surprise. It is Ebola. It dominates the news cycle in the session, in the weeks right up to the election, 2 weeks right up to the election, which of course was a Republican landslide. Step 1, fear of contagion, an old fear. Step 2, politics. Step 3, again an old step. The fear gets linked not to the malevolent actors who are bringing this danger to our shores. It's not just a disease, it's evil people who are going to infect Americans. And this links to pre-existing fears. Tom Tillis, now your senator from North Carolina, says about Ebola, we have bad actors who come across our borders. We need, again, the same message, to seal our border and secure it. Or our friend Chris Christie, we have a clear and present danger, the danger of ISIS flying terrorists with Ebola into the United States. Here's the confluence. In Ebola panic, an old story, with a them, number 1, we have porous borders. People are used to hearing about immigrants coming in. Linked to them, number 2, terrorists, ISIS, harm to Americans. Again, a very old story. Bad actors threaten American innocence. We've seen it over and over again. Those of you who study drugs know that most drug panics in the United States have been panics about a particular class of people. Opium, smoked opium had to do with Chinese men seducing white women, marijuana with Latinos, crack cocaine with you-know-whom. And they get into all kinds of panics. There was a panic in the 19th century about, how to put this delicately, self-pollution. You see, the Irish nursemaids, to teach children how to be quiet in bed, would teach them how to pollute themselves and to masturbate. And this was this great threat that somehow we had to control our borders against the Irish. You see this in the discourse of Ebola. Some them is threatening us, and we have to protect ourselves. Step 1, fear. Step 2, politics. Step 3, a malevolent them. Step 4 is something quite new, and that's the incompetence narrative. I haven't seen this linked in the past, and it's important, linked in the past to these fears of others. The incompetence narrative, well, I'll just quote one, but you could see it all over the conservative press. Why is it that many people have no faith in Washington, D.C.? Perhaps the state, this is from an article in the National Review, but there are lots of them, and I'll quote a couple. Perhaps the state really is terrible at reacting to crisis. Perhaps people have watched the most domestically ambitious administration in a half-century flail and collapse in ignominy. And after that, many Americans are a touch more apparetic, that means doubtful, today. Liberals are not willing to say, perhaps the government itself is to blame. So fear, politics, a malevolent them, and the incompetence of government to respond to all these things. Let me conclude by telling you what I think is new and what's old, and how it all adds up as a commentary on American culture and politics. 1, it's a familiar fear. In times of great change in the United States, people do worry about how the country is changing and what others are bringing to our shore. And this notion of a malevolent them typifies periods of great change, and particularly certain kinds of change in the United States. This is a period of great change, first of all, because it's the second highest period of immigration. And we know that periods of immigration, if you're a historian of immigration, we know periods of immigration, high immigration, create anxiety. For good reason. It changes what it means to be an American, and many people don't want that changed. So it's a period of high anxiety. Today we also have a period, very interestingly, of racial change. 2012 was the first time since 1640-something that the majority of people born in the United States were born to parents who don't identify themselves as Caucasian. It's an enormous change in American politics and American history. And that a first step in a route towards a majority-minority, as we call it, that ironic term. Well, that's a period that creates this kind of change. Immigration and racial change touches the great American anxieties. Moreover, second point, this has been famously a land of opportunity, the United States, and that we've gone through periods of gilded ages and great inequality and periods of equality. We're now in a gilded age, a period of great inequality. And so the question becomes, particularly for people feeling left behind, who's to blame? There's an easy answer. It's the them who are coming across the borders. A very easy answer, but one we've seen many times in American history. So, familiar fear, times of great anxiety, there are strangers, and Ebola symbolizes that. I went to a website to see the latest data, and what did it say on top? Sign the petition, tell Obama to protect our nurses and prevent Ebola. There's sort of image of change and threat. But there's two things that are new that this classic set of fears triggers in American politics today. New thing number one, we're in a hyper-partisan era, unusually partisan. And that's partially because it used to be that there were liberals and conservatives in both parties. The Democratic Party was full of Southern Democrats, some of the most conservative people in America, and Northern liberals. So each party had to sort out what their politics was. Now, for the first time, our parties are sorted purely by ideology. If you're a liberal in the Republican Party, you really are clueless. Likewise, a conservative in the Democratic Party. Very few of those left. As a result, our partisan politics have become very intense, very ideological, and they begin to predict people's opinions in a way nothing else does. Pew did this wonderful study in which they asked people 40 questions about values, politics, and so forth.
And it turns out if you say you're a Democrat or a Republican, that is more predictive than anything else, more than education, more than income, more than gender, more than race. And remarkable that it's about 50% higher what your party is than what your race is. And that's unprecedented in American politics and history. It's like the old joke, the Italian girl who comes home, "Mommy, Mommy, I want to be a prostitute." "What?" I want to be a prostitute." "Oh, thank God. I thought you said you wanted to be a Protestant." For Protestant, place Democrat or Republican. So that's the new context number one. And the final thing I'll say, the new context number two is this: we've always had a dread of government. Americans always have been suspicious of their government. But now it's a party platform. One of the parties, these intensely felt parties, believes that the government is incompetent and makes the case on government incompetence, whether it's an Obama rollout or Iraq or ISIS or the children coming across our border or Ebola. Each one of those is an example of the fundamental incompetence of the American state. Now, you'd have to say 9 cases, 1 death, pretty good protocols. We'll hear more about this. But you'd have to say overall that the Americans probably handled their cases really quite well. There's people who know more about it than I do here, but the protocols seem to have worked. But the anti-government narrative remains in place, which is there's no one to say, you know, that Obama healthcare plan, after those little glitches, which were unpleasant, working pretty well. There's no one to say the Ebola crisis handled pretty well. That is, the anti-governmental narrative is left to stand, and oh, what work it does. It is true that public health systems are one of the things you say when you're looking for what countries are staggering under Ebola, but you'd also say among very rich countries, having poor public health systems matter, and we have a poor public health system. The anti-government narrative that says government can't do anything right, look at this or that or the next case, that makes it much harder to turn to a public health system and build it up the way it has to be built up. And going back to the problems I've been mentioning before, we've got a crisis, many of us believe, in inequality in the United States. The constant narrative that the government can't do anything right makes it far more difficult to mobilize national resources. It locks into place the current winners and losers. So I guess this is a call to action. Government does many things right. Our governmental systems, our healthcare systems, I think, did this right, and someone needs to say so. Thank you.
Hello. Thank you, Dr. Malone. That was a perfect segue. So I'm Nicole Alexander Scott, an adult and pediatric infectious disease physician, and I have slides that I know have been received, so I'm going to put them on. Excellent. So we are going to talk about some of the public health system response that has occurred here in Rhode Island. In addition to my clinical role as an adult and pediatric infectious disease physician, I have the distinct honor of also consulting as a medical director at the Department of Health, who has been significantly engaged in the public health response. And so we'll share some of that for a few minutes and then be able to get into some questions. So Dr. Levine covered a good portion of the medical aspect of this. We're all familiar with Ebola virus. What's helpful is remembering that there have been several outbreaks that have occurred since 1976. So while this is relatively new and for sure the worst outbreak in the history of the world regarding Ebola virus, we do have several years of research that has been extremely helpful in laying out the public health response that we depend on now. This is a helpful slide to keep in perspective where Ebola virus fits in terms of contagiousness. So the number of people that one sick person will infect on average, as many of you know, is called an R-naught. And here are the maximum values for a few viruses, the average for them, and being able to see where Ebola virus fits on the spectrum is quite helpful. So the least contagious on this list are hepatitis C, where one sick person can infect 2 people, and Ebola virus, where one sick person can infect 2 people. Both of those are less than HIV, where one sick person can infect 4 people, as well as SARS, that many are familiar with from several years ago, which is also an R-naught of 4. Mumps and measles are much further along. Measles in particular, where one sick person can infect 18 people. So it's helpful to keep that in perspective for where contagiousness falls with Ebola virus. It's already been discussed that it's spread through bodily fluids. The list is exhaustive of the bodily fluids, noting that blood is most significant. A person who becomes infected can become so by touching or handling someone who is sick with Ebola, objects contaminated with body fluids, or the body of a deceased victim. And then the virus has to enter the body through some form of a mucous membrane, touching the eye, the nose, or the mouth, as well as an open cut, wound, or abrasion. And then sexual contact is an important component as well. It's helpful to be reminded, or to remind colleagues or members of the public, that Ebola is not spread by air, water, or food, except for bushmeat that may be contaminated. It's also not spread by mosquitoes. And most importantly, in terms of our public health response, it's not spread by people who do not have symptoms of Ebola virus disease. Dr. Levine already went through the list of symptoms. What's important to know is that if you are not sick after 21 days since your exposure, there is no further risk of becoming sick with Ebola virus. And that, again, is a reflection of the years of research that we've had to be able to study this disease. This is also significant in terms of putting together the public health response component that many are familiar with. This is also a helpful slide in terms of understanding the diagnostics related to Ebola virus. When symptoms develop within a few days, the amount of virus in the blood is the first thing to increase or develop. Many of you may or may not know that the PCR test for Ebola virus usually does not detect disease, or may not detect the virus, until at least 72 hours of symptoms have occurred. So if we test someone who's less than 3 days with fever or some of the other symptoms that are mentioned, they may have a negative test. If there's still concern for Ebola virus, the important thing is to test again after that 72-hour period, because as you see, that's when the amount of virus in the blood, the viremia, begins to peak. And that's when you can best detect it by the PCR test. And then subsequent to that, days into the illness are when our antibodies begin to develop. And there is testing to identify both IgM and IgG antibodies. And the IgG have been known or demonstrated to go on for at least 10 years after illness. This also gives a sense of Ebola virus in bodily fluids and how long it can last in bodily fluids. So viremia, or the amount of virus in the blood, as I mentioned, is the most significant, particularly in terms of transmission. It's certainly present throughout the first 2 weeks of illness, and then can begin to decrease once you go beyond 21 days. And what's being done within our borders is, in order to determine that someone has been cleared of Ebola virus, is that they have at least two negative Ebola PCR tests that are done to say that a person has recovered adequately. But this also shows some of the other bodily fluids where Ebola virus can exist that have been mentioned, and for how long. In addition to highlighting the blood as the most significant bodily fluid, the other important fluid to highlight here is semen. That is the one bodily fluid that has demonstrated evidence of detection almost 3 months out from illness. And because of that, our recommendations for anyone who recovers from Ebola virus is to avoid unprotected sexual activity, including oral sex, for at least 3 months after they are infected and recover. So this has already been discussed as well. It is quite complicated in the sense of the amount of fluid balance that's required, maintaining electrolytes. Definitely kudos to Dr. Levine and the many physicians in the world that have done an amazing job trying to provide that intensive supportive care that's necessary for patients. We know also that there is no vaccine as of yet. There is a phase 1 trial already developing, and people are working on having some level of vaccine available. But for now, our public health management is the key. I really appreciate the opening statement that Ebola virus is not a disease of people, that Dr. Levine said, but a disease of healthcare systems. So contact tracing, identification of all cases, and isolation are proven mechanisms that work. And in the talks that I've been giving on Ebola virus, I think it's important to highlight what Nigeria has accomplished in emphasizing the effectiveness of a public health response. Nigeria had 20 cases, unfortunately 8 deaths, and over 980 people were contacted and monitored for the 21-day period via contact tracing to make sure that there was no further spread of disease. And Nigeria has successfully and effectively, with activating their incident command system for the country and implementing this documented public health response, have stopped further spread in the country. As of October 5th, there have been no further cases, and Nigeria is no longer one of the countries of concern that we mentioned. I think that is key to highlight, both for countries in West Africa and for people here in terms of addressing the fears and the concerns. This is something that is possible to stop. Keys to stopping the spread: contact tracing, monitoring those with risk of exposure for 21 days, making sure that healthcare providers and healthcare facilities are prepared and protected, and effective patient treatment. So what have we been doing in Rhode Island? The Department of Health, as I mentioned, has had extensive preparedness and a response plan in place. We've been working on this in terms of communications since late July, early August. Since mid-October, we've activated our incident command system and have worked closely with the Rhode Island Emergency Management Agency. It has been a collaborative effort. The Rhode Island Ebola Response Plan has been completed and made available to our legislators and approved by the governor. And some of the strategies that have been implemented include our symptom monitoring and movement plan, which is significant, and I'll go into a little more detail. Additional plans include evaluating and monitoring those who are persons under investigation, also contact identification and monitoring, as well as preparing for event demobilization, evaluation, and expansion. The Department of Health, through myself and other colleagues, have provided subject matter expertise for high-risk contact housing and support services, for medical waste management and decontamination, and certainly working in collaboration with the Centers for Disease Control, who has been tremendous in offering guidance in each of these steps. Other components of the strategy include assessing and improving the healthcare system's ability to respond to Ebola. The hospitals have been working extensively. Whenever someone asks, are we ready, I can confidently say that I have an endless number of colleagues who have given blood, sweat, and tears to making sure that our hospitals are prepared. There's a stress testing process that has been going on with the hospitals and the Department of Health, working together to go through a drill, so to speak, and see what can be improved on, what can healthcare facilities do to best prepare, and what can the Department of Health do also to provide the support that's needed. Also, personal protective equipment training has been initiated in various facilities throughout the state. Additional aspects of communication include providing clear, concise, and instructional information throughout the state through either clinical information support and guidance, as well as offering regular conference calls to agencies and providers and other partners across the board, ranging from funeral home directors to school nurse teachers to infectious disease doctors, on and on. We've also administered and published partner and provider briefings, as well as offered guidance for specific groups. The Department of Health website has an endless number of resources available for the public, for providers, and for many of the partners that I've mentioned that we've reached out to. And then there's a health information line that's available for anyone in the public if there are ever questions about Ebola. That's 401-222-8022. That's something that can be offered. And then there have been presentations at public venues, as well as ongoing media relations. These are a few of the partners that I've mentioned we have communicated with, offered guidance to, had conference calls with, sent publications, and had discussions with in terms of planning an Ebola response. What's been tremendous in this response effort is the amazing West African community that has mobilized and really led the way in terms of the response that's necessary. And the Department of Health, since July, August, has been collaborating with our West African community. There was a State House rally in August. There was a State House vigil in October that the governor was at, and many of our Department of Health colleagues. The Ebola Be Gone campaign has been initiated and is truly led, particularly by the youth, who have done a phenomenal job. There are weekly meetings with the community that are ongoing, church and other community members that myself and others have been a part of. Flyer distributions, supply drives, relief funds have all been crucial, an important aspect of this response. So to get into the CDC monitoring and movements guidance, some of the key points are to be aware that restriction for any travelers is limited to 5 airports that any travelers to West Africa have to return to. And with those 5 airports, once a traveler returns, the information that they have is given to any Department of Health in the state that they return to. And for Rhode Island, As of November 7th, we have been monitoring all travelers that have returned to our state for at least 21 days. And so it's important to recognize that there is not an infinite number of travelers that are out there that we're not aware of, but we are familiar with everyone who has traveled and are monitoring them every day, checking for symptoms and making sure that they're equipped on what to do. And so these are some of the numbers. There are currently 22 low-risk travelers who are being reported. 5 have already completed active monitoring, and 15 are currently under active monitoring. And then it's important to be aware about healthcare workers, which Dr. Levine has also already shared on. So I'm going to stop there and move on to the next segment of our discussion, but it's an honor for me to be a part and available to answer questions. Thank you.
Thank you all for those for still sitting down and waiting. I said I'm going to speak briefly about Nigeria and culture, the implication of culture in containing Ebola. I know that our time is limited now, so I'll just summarize what I intended to talk about and just mention the main points. Hopefully, during the question and answer, we can elaborate in some of those points. We know that Ebola, this current Ebola case started some time ago in 2013, and that is in Guinea, and well, people did not really know about it. And it was not until it spread to Guinea, Liberia, and to Sierra Leone and Liberia that it started trickling down into the media. However, in July 20 this year, the news broke that Ebola has entered Nigeria, and that was when all hell got loose, because we all know what it means. I could have raised some quotation from WHO on the implication of Ebola entering Nigeria. The problem is that Nigeria is highly populated, and there has been a lot of problem going on in the country and still going on now, like the Boko Haram and the implication of that. Will it be contained? It means that when Ebola got into Nigeria, there's high tendency, according to WHO, that it will spread to other parts of the world, and also because of high migration rates in the country, in and out from other places. So it became a big issue. Ebola became a topic that is heard all over the media because it has gotten into Nigeria, and there was reason for that fear. The reason for the fear is because people were not sure that Nigeria could contain Ebola. How, I remember that late July, my sister-in-law called me and said that I should pray because one of the nurses in her school was infected. Apparently, at the end of June, she resigned from the school and started a new job in the hospital where the first carrier, Patrick Sawyer, was treated, and she was the first contact. So she died tragically from that contact, and it became a big panic in the country. But it was contained. Now, I just want to highlight the reasons why how Nigeria was able to contain it, because so many people have asked me, how could Nigeria contain Ebola when they could not manage Boko Haram? So it's a legitimate question, I have to say, because of the way things are in the country. Number one, the political situation in the country right now is very volatile. It has been for quite a time, for about 2 years now. But as time goes on, especially during this year, when with the intention of the current president to run election, it has been very high. The tension has been very high in the country. There's a lot of violence going on in the country. So there's fear that when this happens, it will be a big challenge. However, when Ebola came in, politics was put aside. So that's one major problem, one major thing that happened, way that they were able to contain the problem in Nigeria. The political tension that was going on in the country was completely put aside. All the political parties that were fighting on each other's, holding each other's truth, put those fights aside, because number one, Ebola has no religion, it has no ethnicity. That's what the two major issues in the country. Unlike the US, where you have a lot of partisan going on, our partisan is drawing on ethnic religious line. And of course also, Ebola does not fear region. So politics in Nigeria, which is the cause of major problem we are having, had to do with region, ethnicity, and race. I mean, and region, ethnicity, and religion. So within these things, of course, everybody understand that this disease will not ask you what religion, what region, or what ethnicity you are from. So that's number one thing that happened. Then another thing that we noticed is that, of course, because of this less political tension, the presidency, the leadership was able to harness and mobilize every sector of the society, and they went for it aggressively. Immediately, the disease was detected, which of course took 2 to 3 days. As Leven have noted that the symptoms is similar to malaria and typhoid. So the first thing people look at is malaria and typhoid, which is why it took 2 days for them to be able to detect is Ebola. And most people that were contacted, and most people that contacted the Ebola virus contacted it before it was detected. So immediately it was detected, the state government took up the case immediately. Government declared emergency and rallied every sector and every institution. And of course, people were also responsive in terms of information, because we also have to understand Lagos, unlike say Liberia or Guinea or probably Sierra Leone, is also a very rich state in the country. So they're not just dependent on the federal government, they could also manage it. They were able to track every contact, every contact of the initial person, and there was also a good facility on the ground. But so because of this, they were able to manage and track, as I think Nicole has already stated there on the board, 900, they were able to track over 987 actually, and monitor those people. At the end of the day, there was just 8 casualties. Another reason why Nigeria was able to contain Ebola is because of understanding of culture, which I want to emphasize here because of our time. There's something that happens that Leven has also pointed out in terms of burial. African culture, they place a lot of importance in the burial. So you find out that people would like to bury their dead, and it's a very traditional thing and sacred thing for them. And it's very difficult to tell people not to bury their dead, which is also one of the reasons the dead body has been the most contagious, and because people tend to get close to that. So the federal government did issue an order that people should not bury their dead. People should not carry their dead to other regions. And in fact, to be able to make sure that that order was followed, they offered that at the end of the whole thing, they were able to give people funds to rebury their dead. So this is part of cultural issue that people most of the time do not understand, especially in places like Sierra Leone, Guinea, or Liberia, where people are so attached to their dead dead family members and friends, which of course make the entire situation more complicated. Then another thing that happens is this: in case of Ebola in Nigeria, of course the literacy rate in Lagos is very high. They have the facility. They were able to use the established tracking unit that was established for polio to track down people. So these facilities were in place. When it comes to, when the Ebola broke up immediately, even when it was also dictated in another state, which is Rivers State, they were able to track these people down and able to monitor them. And because they were also able to have a very strong public awareness in through the media, through social media, through mobile phone, Amber Alert was set, so people were aware, and that helped in creating educating people on how to prevent it, on how to take care of themselves. So in case of Nigeria, managing Ebola, I have a lot of notes here which I'm not looking at now. Managing Ebola was one of those things that people didn't expect, but it has to do with these things, which is the leadership responsibility, the aggressive way the two states that were involved, Rivers and Lagos states, manage it, and of course the mobilization by the federal governments, and recognizing the culture and how people could be attached to the culture to be able to contain it. So this, the issue of culture in this case have been raised in several places, because people ask the question, why is it that in places like Liberia, Sierra Leone, and Guinea, it has spread? And you find that it has to do with not understanding how people manage this. You also find out that the caregivers, which Levan did mention, are people mostly at risk. And most of the time, caregivers are family members. And because family members are not educated in this way, they tend to suffer most. So when it comes to Nigeria, this didn't happen because, of course, they set emergency camps all over the place. And like that, they were people, I believe, and where the perception, the trust was there for them. So moving from the caregiver, personal caregiver was able to they were able to control that, so that cuts down the risk by family caregivers. And so I will say containing Ebola in Nigeria got to do with the leadership response, the emergency that was taken, the infrastructures available, and of course, we also have to understand it was a middle class disease when it came to Nigeria. It didn't come from the street or from the lower class. It came straight from someone that is attending ECOWAS meeting. So he was taken to a very good hospital, which is why they were able to contain it. And, we don't know what would have happened if it didn't happen this way. But I have to give a lot of respect to those health workers and also the leaders. For once, Nigeria was able to do something together. The leaders that took the charge and was able to contain it, because I don't know what would have happened if it wasn't contained. So I think I will stop here now, because I don't think we have enough time and I'm trying to rush. So please ask your questions, and then I think the panelists are ready to answer any question you have. Thank you.
Hello. My name is Fred Obenampofo. I'd like to say thank you for the information that you've given. I was just curious, has any one of you thought about all the conspiracy theories surrounding the origin of the virus? I'm saying this because when I speak I'm originally from Ghana, and in Ghana, there are many Liberians in Ghana and many people from Nigeria and from Guinea. And many people from Liberia and Sierra Leone and Guinea, because during the Civil War, most of them some of them came to Ghana. There has not been an incident in Ghana. However, I have friends, as I said, but what the information out there is that the virus started sometime in 1976. And there is this view that it's the apes, the monkeys, someone got it from the monkeys. I don't know what you guys think about that view. But then, if that is the case, if that really is the case, then I know that back home in Ghana, we eat lots of what Westerners call bush meat. But then for some reason, right here, people do hunt. But right here, people don't call it, when you hunt a deer, you don't call it bush meat. You call it a deer or whatever it is. But for some reason, when it comes to Africa, when we hunt the same kind of meat, the Western media call it bush meat. So I'm really curious as to the implications that it gives about Africa being the whole place, this kind of people who just depend on non-edible food or wherever it is, food that shouldn't be eaten or wherever it is. But I actually want you guys to respond to my question about the origin, because we've been eating what you guys call bushmeat for ages, really, since the beginning of times. There are people who don't think that Ebola really started in Africa. And that's one of the conspiracy theories. But I've really never heard any Western educated doctor or expert like you guys really discuss that. And I don't know why that is the case. Thank you. But I want to say thank you for the information. I appreciate it.
So we actually don't know exactly where Ebola comes from. The best science is that the reservoir is bats, and the transmission from bats to humans occurs irregularly. It doesn't happen very often because of the fact that the virus itself needs to, the bat needs to be eaten by a human, and then that human needs to contract it from the bat, and then it needs to be in a situation where it's going to be able to pass it on to others. And so we think that that's why it occurs very sporadically. The truth is, though, that, again, the eating of the bushmeat is only the way that the first human in an epidemic gets infected, and after that, all of the transmission is from human to human. And I think that, some of the points that were raised, there have been a lot of sort of cultural misperceptions or pointing fingers at Africans because of some of their cultural practices around things like burying the dead and so forth. It's true that in the United States, we also wash the dead before we bury them. We also clean the dead. We also attend funerals. It just happens that we don't have Ebola being transmitted in the United States to allow us to contract it from those dead people. So I think that this is a disease that, as we saw, is not actually spread that easily. The past outbreaks that have occurred have been small and contained, and they've been responded to very quickly, and so we were able to put them out very quickly. And it's not that surprising, then, that it hasn't occurred more frequently than it has. I don't know if that's a sufficient answer, but...
Good answer. I'll just say one more thing. I sense some agitation in your question, in the way you posed the question about perceptions of people. And I think in every country there's a great battle between science and ignorance. And when people are afraid, ignorance sometimes makes inroads on what we know about science. So here you have this very complicated scientific problem, which we're not quite sure exactly, as Adam just said. And it's not limited to any continent or any country, this great conflict between what we know and what people fear. So I would just calm your agitation to say it's not any group or any people or any continent where that battle takes place, and we very much know it here as well.
I'm saying this because, it has so many similarities with, the origin of AIDS. And I like to say I'm an African, I'm proud to be an African, but I don't think it's right that, you know, unfortunately, you know, the people who are dying from AIDS, it's not like, you know, my families, you know, because fortunately for me, my families, you know, are not in the lower class, you know, back in Ghana or wherever. The people who are dying are those people who don't have the voice in most of these African countries. While I blame, you know, some of my governments, African governments, you know, for not being prepared to really handle this, I still don't feel it's right that the origin has to come from Africa. And many people that I speak with, when I speak with people who are home, they don't believe that. But then that, you know, the view here is that, you know, it started in Africa sometime in 1976. And I still don't get that, you know, if the direct correlation, because if it really started in Africa, how come is it that it didn't start before 1976? So, like, we've been eating what you guys call bush meat since the beginning of times. And it's unfortunate that right now in Ghana, those people who have that as their business is way down because people are afraid to catch Ebola.
If I may intervene, I don't know if anybody can really address that right now, but I think we can discuss more about it at the end, so that we should give other people some time to ask questions. So let's talk later on too. You can speak with the panels later on.
Stephen Buca, Chairman of the Department of Epidemiology, and I want to thank the panelists and Professor Lowry and the Watson Group for putting this together. Very interesting. An observation that hopefully maybe connect many of the different topics. It's ironic that the risk to folks in this country is the lack of attention in Western Africa and letting the disease become endemic is much greater than the risk of an epidemic or acute outbreak here in this country. And again, the irony is it's been the lack of attention from the West to what's happening in Africa that's increased the risk for the Western countries. So I wonder if there are any comments on that.
Yep, it's certainly a key element in the communication and response effort. In participating in a Senate hearing yesterday evening at the State House, it was one of the important messages that were highlighted that the representatives acknowledged, that in order for us to properly implement a response, we need to dedicate our efforts to what's going on in West Africa. I think we are at that point where we probably have been many times in history, where we have to connect the concept of that with the reality and actually seeing the money that was promised come through, actually making sure that there aren't barriers to healthcare workers going, and actually making sure that the resources that are needed to build the infrastructure in Sierra Leone, Guinea, and Liberia in particular are put in place. And it certainly ties in some of what young gentleman was expressing, and becomes quite complicated, but at the end of the day, with this being a disease of the healthcare system, that's clearly where the effort has to go. It just requires constant re-education among our colleagues.
Yeah, I'll point out that, you know, I've been in many different humanitarian emergencies, and this is by far the one with the fewest number of responders on the ground for the scale of the problem. And, you know, when I was in Haiti after the earthquake, humanitarian responders were tripping over each other because there were so many there. And in Liberia, there were so few, I could count on one hand the number of American doctors there. In fact, most of the response was local Liberians, as it always is in humanitarian emergencies, But even among the expatriates, the majority of expatriates there were actually from other African countries, from Uganda and Kenya and so forth, coming to help. So, it's really kind of sad in that way when we have so many more Americans actually than there are Ugandans, but yet there were more Ugandans in Liberia helping than there were Americans. And in terms of helping end this epidemic, it's going to take a lot more people on the ground and a lot more money and a lot more support. But it's in our best interest, because if we do end the epidemic, then we don't have to worry about it coming here.
Hi, my name is Jeanette. This is mainly a question for Dr. Levine. I'm wondering, you mentioned that, or nice segue from what you just said, so it's possible to control this epidemic, but how likely, having seen what you saw in the field, and then maybe Nitsan, Professor Shora, of what you know about the WHO, how likely is that to actually happen? That graph you showed us at January 20th could be like the breaking point. Like, how optimistic are you?
Good question.
Well, I mean, there already are some signs that things are getting better in small places, at least. I know in Bong County, where we set up our Ebola treatment unit, the number of cases has dropped significantly just because we're breaking the train of transmission there. I'm not going to predict the future. I'm not an optimist or a pessimist. The cup is not half empty or half full. The cup is exactly twice as large as your available water supply. If you want more water, get more water. And so it's all going to come down to what we end up doing over the next few months and years.
Hi, my name is Melissa. I'm a student here at Brown University. My question for you is if any specific factors have been identified that have contributed to the size and magnitude of this outbreak compared to past outbreaks that have been significantly smaller and easier to contain.
I wanted to actually highlight those things when I was talking about Nigeria. I think one of the major problems with this case is Liberia and Sierra Leone are post-conflict countries, and there's so many infrastructure broke. A lot of the infrastructure has been broken. I mean, the impact of war. So, and also what happened is this: in most of the area where these things started, it was difficult to identify initially because of the symptom similarity to malaria and typhoid. That's another thing. Then the spread was quite fast, rapid, and because because of the area it broke is also they're very poor. So identifying it matters a lot. Before it was identified and tracked patients, it was too late. And it's difficult to do, and there is also a lot of distrust in both countries between the citizen and the government because of post-war impact of the contract. These are one of the reasons that you find that made it at least spread more and in this magnitude. I don't know if you have more, since you did.
Yeah. I mean, I'll also say, so all 24 previous epidemics occurred in very rural areas, far from paved roads, and this epidemic occurred near a paved road. And so that allowed it to spread much more quickly to the capitals, such as Conakry, and then eventually to Freetown and Monrovia. And that allowed the epidemic to spread much more quickly than it has in past epidemics. When it takes an entire day to walk from one village to the next, that's going to be very hard for a sick person to do. But if somebody can get in a car and drive to a new town, then it's going to be a little bit easier for them to spread it. I'll also say that, in 1995, a decision was made by all the big humanitarian organizations, basically, that one organization would handle Ebola, and that organization was Médecins Sans Frontières, or Doctors Without Borders. And it made sense at the time because epidemics were very rare and they were small and it was very complicated and difficult to respond to them. So it made sense for one organization to develop all of the expertise. And that was part of what happened. The problem in this epidemic is that the only organization with the expertise to respond was MSF. And when they became overwhelmed early on in the epidemic, there was really nobody else with any expertise to step in. WHO didn't have expertise, the other NGOs didn't have expertise. And so a lot of what has been happening over the last few months is catch up, where everybody's learning, how to work these protocols, how to actually use the PPE, how to operate within it so that they can come and respond to the epidemic. So it's really sort of a tragedy of history in that way.
Thank you for speaking today. I'm a graduate student at the School of Public Health. Currently, we're operating as a government without a Surgeon General due to political reasons. And I'm just curious if anybody on the panel has any thoughts about how the American response or the sort of media response here, or even the response actually in Africa, may have been different had we had an acting Surgeon General.
Media response.
Well, the one thing to say is the Surgeon General stands for science in the public interest. That's what the Surgeon General does. That the great AIDS epidemic, suddenly a quite conservative man stepped forward and was really extremely articulate in an era when the United States didn't want to confront the reality of AIDS. So this is a symptom, I think, of not just partisanship, but a lack of attention to public health infrastructure, that there isn't someone to stand for science. It really goes back to, your question earlier about who stands for science in the public interest. And that at least in the United States, I think it's really difficult. The whole Surgeon General's apparatus, the whole public health service has been allowed to erode, and it's a great symbol not to have someone who says, look, folks, as we did with AIDS in a Republican era, look, folks, here's what the science looks like. And so I think it's a really astute question, and it's symptomatic of a trouble in our own commitment to science and to public health. So hopefully once you get your degree, you'll help change that.
Hi. Thank you for a great talk. I'm a student in the sociology department. And I'm wondering, people have talked about there was also a lack of pharmaceutical research and research on vaccines that could have been developed if this wasn't a disease that was not, of the first world. So I was wondering whether you could comment on that, or whether there's really nothing else we could have developed for this disease.
So that's a great question. Essentially, to what extent do we think politics and stigma are contributing to the development of vaccine availability and treatment options for Ebola virus? My personal perspective is it's something that is probably not quantifiable. Certainly, history shows that many decisions are not made separate from politics and stigma, but particularly within medicine, the hope is that you would do no harm and, especially at a public health level, do what is necessary for people across the world, regardless of the continent that they are on. That being said, I do know also, as has been mentioned, with Ebola previously being limited to smaller areas without much spread, in addition to Doctors Without Borders being sort of the only world experts capable of caring for Ebola, there was naturally not a lot of energy or resources or thought put into treatment options to the same extent. So there is also an element of catch-up that's in place right now. And it is good to see some of the progress that is ongoing and plans for accelerating that. And then the rest will play out from there.
I think about it not so much in terms of culture and stigma, but political economy and marketability, right? I mean, so there are two problems here. One is that there are not very many people who get infected, and the ones who get infected do not have the money to pay for expensive diseases, right? So there are no market incentives for pharmaceutical companies to invest in the development of the drug. It relates a little bit to what I said about the fragmentation of the international health regime, in the sense that this is one thing that the fragmentation actually does help with, right? So the World Health Organization does not, in general, is invested in developing new drugs for what we call orphan diseases, but there are other public-private partnerships today, such as the DNDi, which is funded partly by MSF, that does try to compensate for the lack of interest in the private market in order to develop drugs for these kind of neglected diseases. Again, they also play the number games, right? So they are more concerned with diseases that are more prominent or prevalent than Ebola. But the question is very relevant, obviously.
Question? I think we're done. We actually have exceeded our time. Thank you very much for those of you that have stayed. And we'll thank all our panelists for, your contribution has been amazing. Thank you so much. I'm sure we're all well informed after today. Thank you.